Welcome back to the Deep Dive, the place where we take these, well, really complex stacks of medical, scientific, historical sources, and we try to pull out the core knowledge you really need.
Yeah, make it digestible.
Exactly. And today we are diving into something pretty fundamental in pathology: hypersensitivity. It's this kind of weird situation where the body's own protector, the immune system, well, it turns on itself.
It really is the ultimate biological paradox, isn't it? You have these systems, evolved over millennia, designed specifically to spot and wipe out threats,
Right.
and then suddenly they're behaving in ways that are excessive or, totally misdirected, or maybe just poorly controlled, and the end result is tissue injury mediated by the immune system itself.
So our mission today isn't just to define this kind of betrayal, but to really understand the structure behind it. The four distinct ways this damage happens, the famous type through wall.
And getting that underlying mechanism is it's everything. It's the key to predicting what kind of pathology you'll see and, crucially, designing treatments that actually target the problem.
Okay, so we're going deep. Cellular, molecular triggers, the whole thing. All right, let's start right at the beginning then. If the system is meant to protect us, what exactly is hypersensitivity? Is it just like a really, really bad allergy?
It's definitely broader than just allergies, though allergies are a big part of it. Hypersensitivity, basically, is any immune reaction to an antigen that's excessive or, frankly, harmful and results in tissue injury.
Okay.
The critical bit is that the injury itself is caused by the immune system's own tools. Antibodies, complement proteins, T cells, those inflammatory cytokines.
So it's not that we're fighting off a bug badly, it's more like we're fighting something or maybe nothing too well. Or in the wrong way.
Precisely. The immune system often has tremendous power, but the regulation, that's where things go wrong. When you look at the chronic, severe hypersensitivity diseases, especially autoimmunity, the root cause is often this imbalance.
An imbalance, how?
Well, you've got these incredibly potent effector mechanisms, the attack systems, but there's a catastrophic failure in the control mechanisms.
The stop signals.
Exactly. The systems that are supposed to dial things down once the threat's gone, or crucially in autoimmunity, prevent the system from recognizing our own tissues as foreign in the first place.
Right.
That failure of normal regulation is key.
And the trigger for this overreaction, the antigen, it can be something from outside, leading to allergies, or it can be part of us, leading to autoimmunity.
That's the critical split, yeah. When the trigger is an exogenous antigen, something from outside like dust, pollen, maybe a drug or microbes.
Things we typically think of as allergens.
Right. That gives you the classic allergic responses. Could be anything from, a minor itch to fatal anaphylaxis. But when the trigger is endogenous.
Meaning self.
Yes, a self-antigen, a protein or a cell bit that belongs to us. That's when we get into autoimmune diseases. The immune system is attacking the body itself.
It really does sound like a kind of cruel biological lottery. Why do some people get these awful misdirected reactions and others just don't?
Well, genetics plays a huge, undeniable role. We know the tendency to develop both allergies and autoimmune hypersensitivity diseases runs strongly in families. It's highly heritable.
So it's in the genes.
A lot of it is. While many different genes are involved, there's a really consistent, powerful link to the HLA genes. They're on chromosome 6.
And HLA is involved in presenting antigens.
Exactly. HLA molecules present antigen fragments to T cells. So if you inherit a particular set of HLA genes, your immune system might be predisposed to recognize, say, a common pollen protein as a major threat.
Or worse.
Or worse, it might fail to learn tolerance to your own tissues, essentially permitting a severe autoimmune attack.
Yeah.
Your specific genetic profile can really set the stage.
Okay, that framework brings us to the classification. The four types, I, T, 3, and 4. If the end result is always tissue injury, why is splitting them up by mechanism so important? Why do we care?
Because the mechanism dictates absolutely everything else.
Like what?
Like the timing. How fast does the reaction happen? What kind of damage do you see? Where does the damage happen? And maybe most importantly, from a clinical standpoint, what's the right way to treat it?
Ah, okay.
If you mistake a type 3 reaction for, say, a type 3, you might choose a treatment that's completely useless or even harmful. A reaction driven by those circulating immune complexes that's type 3 needs a totally different approach than one driven by T cell killing, which is type 4.
Right. So let's just quickly sketch out the four types before we dive into the nitty-gritty of each one.
Sure. So high level, type 1, this is immediate hypersensitivity, driven by IgE antibodies binding to mast cells.
Oh.
Super fast. It's your classic allergy.
Okay.
Type 2, this is antibody mediated. Here, IgG and IgM antibodies target antigens that are physically fixed onto cell surfaces or in the extracellular matrix.
Stuck, right. Fixed targets.
Type 3, immune complex mediated. This also involves IgG and IgM, but they bind to soluble antigens floating around in the circulation. These complexes then get deposited in tissues.
So circulating damage that settles somewhere.
Yep. And finally, type Yahweh T-cell mediated. This one's the odd one out because it doesn't involve antibodies at all. It's all about T lymphocytes, both helper and cytotoxic T cells, and it's characteristically a delayed reaction.
What's really interesting, though, is that the source material mentions these aren't always neat little boxes, right? A single disease might actually involve multiple types.
Absolutely. That's a key point modern pathology is emphasizing. Something like lupus, systemic lupus erythematosus, it's a great example. You can clearly see elements of both type 2 antibodies against blood cells and type 3, those immune complexes, depositing in the kidneys happening at the same time. It just shows how complex the whole system breakdown can be.
But to understand that complexity, you got to master the basics first.
Exactly. You need the building blocks. So let's start with the most dramatic, the fastest one, type I.
Okay, type I. When someone says allergy, this is almost always what they mean, right? It's super fast minutes, you said, and it happens in someone who's been exposed before. They're sensitized. How does the body get primed like that?
Yeah, the sensitization process is absolutely crucial. And it all hinges on pushing the immune response down a specific pathway, the Th2 pathway.
Th2, helper T cell type 2.
Correct. In people who are genetically susceptible, we call them atopic individuals when they first encounter an allergen. That exposure preferentially stimulates these Th2 helper T cells, usually in the lymph nodes, draining that area.
And these Th2 cells, they're like the directors of the allergic response. What signals do they send out?
They release a very specific set of chemical messengers, cytokines. The key ones are interleukin-4, IL-4, IL-5, and IL-13.
Okay.
Now, IL-4 is really critical for setting things up. It basically tells B cells, hey, stop making the usual antibodies like IgG. Switch over and make tons of this special type IgE.
Ah, IgE. That's the antibody specifically linked to allergy.
That's the one. It becomes the sort of dangerous ammunition in this scenario.
So the B cells pump out IgE. What happens to it then? Does it just float around waiting?
Not really, no. It doesn't stay free for long. IgE has this incredible high-affinity receptor waiting for it called FKRI Fc epsilon R1.
Okay, bit of a mouthful. Where are those receptors?
They're found in huge numbers on the surface of mast cells, which live in our tissues, and also on basophils, which circulate in the blood. The IgE binds really tightly to these receptors, essentially coating the mast cells.
So the mast cell gets armed?
Exactly. It's armed and ready. A single mast cell sitting in your airway lining or your skin could be covered in thousands of these IgE molecules, each one specific for whatever allergen started this whole process. That state mast cells coated in specific IgE, that's sensitization.
Okay, so the trap is set. Then the trigger comes along, you get exposed to that same allergen again. What happens at the molecular level to make the mast cell basically explode?
Right, so the allergy comes back in. Because most allergens have multiple spots where IgE can bind their multivalent, it links up with several IgE molecules on the mast cell surface at once. And crucially, it cross-links adjacent IgE antibodies.
Pulls them together.
Yes, it physically pulls the IgE molecules and the underlying FKRI receptors they're attached to closer together. This proximity triggers a massive signaling cascade inside the mast cell. Think of it like flipping a master switch.
And the result?
Explosive degranulation.
Yeah.
The release of all the preformed chemicals stored in granules inside the cell, plus the rapid synthesis of new inflammatory mediators. It's a double whammy.
And this leads to the two phases of the reaction that you mentioned, the immediate and the late phase. Let's break those down because that really matters for how you treat it, right?
Absolutely critical. So the immediate reaction phase.
Right.
This is what hits you within minutes.
Got
It's
it.
caused mainly by those preformed mediators bursting out of the mast cell granules.
What does that look like symptom-wise?
Think rapid effects. Vasodilation, blood vessels widening, profound vascular leakage, which causes swelling or edema, and intense smooth muscle contraction. That means bronchospasm in the lungs, cramps in the gut, potentially life-threatening swelling in the larynx. This immediate phase is what can cause anaphylactic shock and kill very quickly.
But it doesn't just stop when the granules are empty, does it?
No, absolutely not, because then you transition into the late phase reaction. This typically kicks in around 2 to 24 hours later. And here's the kicker. It happens without any more exposure to the allergen.
Really? Why?
Because it's driven by the stuff the mast cell made during that initial explosion. The newly synthesized chemokines and cytokines, these act like delayed action signaling flares.
Calling in reinforcements.
Exactly. They recruit a whole new waves of inflammatory cells into the area, especially eosinophils, but also neutrophils and more T cells.
And the second wave, this is what causes the more chronic damage, like an asthma.
Precisely. The late phase isn't about immediate shock. It's about sustained inflammation, tissue infiltration, and actual tissue destruction. Think about the mucosal damage you see in the airways in chronic asthma. That's the late phase reaction doing its work.
Which is why, as you said, the treatment has to target different things for each phase.
Totally different pharmacology needed.
Okay, let's dig into those mediators, starting with the preformed ones in the granules. Everyone's heard of histamine. What exactly does it do in this immediate phase?
Histamine is the main vasoactive immune that gets dumped out. Its effects are super fast and pretty powerful. It causes immediate smooth muscle contraction, like in your bronchi, making it hard to breathe. And it dramatically increases the permeability of small blood vessels.
Making them leaky.
Yeah, leaky. That's what causes the rapid swelling, the edema, the fluid leaking out into the tissues. You also get enzymes released from the granules, like proteases, which can start breaking down the local tissue matrix and also generate more inflammatory signals by activating other systems like complement and kinins. It sort of feeds itself.
But the source material really emphasized the newly synthesized mediators, especially the leukotrienes. You said that's where it gets exponentially worse.
Yeah, this is where things get really potent. After the initial trigger, the mast cell machinery kicks into high gear to synthesize powerful lipid mediators. The big players here are leukotrienes C4 and D4.
They're not stored, they're made on demand.
Made de novo, exactly. And here's the key fact. These leukotrienes are orders of magnitude, literally thousands of times more potent than histamine, at causing smooth muscle contraction and making blood vessels leaky.
Wow. Thousands of times.
Yeah. They, along with another lipid mediator called prostaglandin D2, are responsible for the really intense, sustained bronchospasm and the massive mucus secretion you see in severe allergic reactions like asthma. PAF, platelet activating factor, is another player synthesized here.
Okay, so that explains a lot. If someone pops an antihistamine for hay fever, they're blocking that initial histamine hit.
Right, tackling some of the immediate sneezing, itching, runny nose.
But if you have severe asthma, the real culprits causing the dangerous prolonged airway constriction are those leukotrienes and then the later inflammation.
That's the crucial insight, yes. So for treatment, to reverse the immediate life-threatening shock of anaphylaxis, you need epinephrine adrenaline. It counteracts the vasodilation and bronchospasm systemically.
Okay.
To block the more localized immediate histamine effects, sure, antihistamines help. But for the late phase reaction that sustained destructive inflammation driven by all those recruited cells,
I need something stronger.
you need potent, broad-spectrum anti-inflammatories. That's where corticosteroids come in. They shut down the production of those inflammatory cytokines and chemokines and dampen down the activity of those recruited leukocytes.
Yeah.
You need to break that chronic cycle.
We should definitely touch on the most extreme form of type I systemic anaphylaxis.
Right. Systemic anaphylaxis is basically a worst-case scenario. It happens when mast cells get triggered all over the body at the same time. Usually this is due to an antigen that gets into the bloodstream, rapidly affect a bee sting, injecting a drug like penicillin, or rapidly absorbing a food allergen like peanuts.
And the result is system-wide chaos.
Total systemic chaos,
Yeah.
Yeah, it does seem backward, doesn't it? The hypothesis basically suggests that our modern, ultra-hygienic lifestyles, especially in early childhood, mean we're just not getting exposed to the sheer diversity and load of microbes, bacteria, viruses, parasites that humans evolved with.
So our immune system doesn't get educated properly.
That's the idea. Evolutionarily, the immune system is heavily geared towards fighting infections, particularly parasitic infections, which often involves a strong Th1 type response. If the developing immune system isn't sufficiently challenged by these real microbial threats, it might not develop the right balance.
It stays stuck on the allergy pathway.
It might remain skewed towards the Th2 pathway, the one that drives IgE production and allergy. So when it encounters otherwise harmless environmental things like pollen or dust mites, it overreacts pathologically. It's almost like an immune system that's bored and looking for trouble because it wasn't properly trained on real enemies.
And just to add another layer of complexity, the source also mentions type 2 innate lymphoid cells, ILCs. Where do they fit in?
Yes, ILC2s. They're a relatively newer piece of the puzzle, but quite important. Think of them as the innate, rapid response arm of the type I reaction.
Innate, meaning they don't need prior sensitization?
Exactly. Unlike the adaptive Th2 cells, which take time to develop memory, these ILC2s live right there in the barrier tissues, lungs, gut, skin. They can be activated very quickly, often by signals released from damaged epithelial cells when an allergen first hits.
And what do they do?
They can rapidly pump out large amounts of IL-5 and IL-13, those same cytokines Th2 cells make. So they can essentially kickstart the immediate inflammatory response, recruiting eosinophils and promoting mucus production even before the adaptive Th2 response gets fully going.
So it shows the speed and maybe redundancy built into this allergic pathway.
Precisely. It highlights how quickly things can escalate right at the point of entry.
Okay, let's shift gears. We're moving away from that explosive IgE-driven reaction of type 1 to type 2, antibody-mediated hypersensitivity. The mechanism sounds completely different here.
It is fundamentally different. Type 2 is defined by IgG and IgM antibodies. But instead of IgE on mast cells, these antibodies bind directly to an antigen that is fixed in place.
Fixed how?
It's either part of a cell's own membrane structure, or it's part of the extracellular matrix, the scaffolding between cells. Because the target is fixed, the damage is usually very localized, right where that antigen lives.
Got it. And once the antibody binds to its fixed target, the source says there are 3 main ways things can go wrong. Let's start with the most direct, just destroying the cell.
Right. This first consequence involves opsonization and phagocytosis. Opsonization is basically just flagging a target for destruction.
Like putting a kick me sign on the cell.
Pretty much. When IgG or IgM antibodies coat the surface of a cell, 2 things can happen. First, the tail end of the antibody, the FDGC region, is recognized by specific FDC receptors on phagocytic cells like macrophages and neutrophils. They see the flag.
Then the second thing,
The antibody binding can activate the classical complement pathway. This generates complement fragments, especially C3b and C4b, which also get deposited on the cell surface. And guess what? Phagocytes also have receptors for these complement fragments.
so the cell gets flagged by either the antibody itself or by complement pieces stuck to it.
Or both. Double flagged. And then the phagocyte comes along, grabs onto those flags, and essentially engulfs and destroys the cell. Eats it.
And where do we see this happening?
This is the mechanism behind diseases where your own cells get cleared out of circulation. Think autoimmune anemia antibodies coat red blood cells, phagocytes eat them, you become anemic. Or incompatible blood transfusion reactions, the recipient's antibodies coat the donor's red blood cells, leading to massive destruction.
Okay, so that's cell destruction. The second consequence you mentioned involves triggering inflammation in fixed tissues, like basement membranes in the kidney or lung.
Yes. This happens when the antibodies bind to antigens that aren't on a cell, but are part of the structural matrix. The classic example is Goodpasture syndrome, where antibodies target a specific type of collagen, type 5, found in the basement membranes of kidney glomeruli and lung alveoli.
So the antibody sticks to the structure, then what?
Once the IgG or IgM deposits there, it again activates the complement cascade locally. This activation releases potent inflammatory mediators, especially C5a and to some extent C3a. These are called anaphylatoxins.
Anaphylatoxins sounds bad.
Hair. C5a in particular is a super powerful chemoattractant. It's like ringing a dinner bell for neutrophils and monocytes, pulling them out of the bloodstream and into that tissue.
Ah, so the damage isn't directly from the antibody or complement, it's from the inflammatory cells that get called in.
Exactly. The recruited neutrophils arrive, they recognize the deposited antibodies and complement, they get activated, and then they just unleash hell. They release destructive lysosomal enzymes, proteases that chew up the tissue, and damaging reactive oxygen species, ROS.
Collateral damage.
Massive collateral damage. This is how you get severe inflammation, tissue necrosis, the kind of damage you see in vasculitis affecting those organs.
Yeah.
The inflammation itself becomes the destructive force.
Okay, but the third consequence is really fascinating, almost counterintuitive. Cellular dysfunction without injury. The cell isn't killed, it just stops working right, or works too much.
This is where type 2 gets really subtle and, honestly, quite clever pathologically.
Oh.
In this scenario, the antibody binds to a specific receptor on the cell surface. But crucially, it doesn't trigger complement activation or phagocytosis.
So no killing.
No killing. Instead, the antibody binding directly interferes with the receptor's normal function. It acts either as a blocker, an antagonist, or as a stimulator, an agonist. It just messes up the signaling.
Wait, how can the same basic thing, an antibody binding a receptor, cause opposite effects, like blocking versus stimulating?
It depends entirely on which receptor it binds to and how it binds which specific part of the receptor, the epitope, it recognizes. Let's take 2 classic examples. In myasthenia gravis, The antibody binds to the acetylcholine receptor at the neuromuscular junction. It physically gets in the way, blocking acetylcholine, the neurotransmitter, from binding.
So the muscle doesn't get the signal to contract.
Exactly. The signal transmission fails. This leads to progressive muscle weakness and fatigue. The muscle cell itself is fine structurally, but it's effectively silenced because its on switch is blocked.
Okay, that's blocking. What about stimulation?
Now look at Graves' disease, a common cause of hyperthyroidism. Here, the antibody binds to the receptor for thyroid-stimulating hormone, TSH, on thyroid cells. But instead of blocking it, this antibody happens to bind in such a way that it mimics TSH.
So the antibody acts like the hormone?
Precisely. It constantly activates the TSH receptor, telling the thyroid gland to keep making thyroid hormone nonstop, completely unregulated by the body's normal feedback loops.
Leading to hyperthyroidism.
Right. So you have one mechanism, antibody, binding a receptor, causing muscle weakness in one disease, and overactive thyroid in another. It just depends on the target and how the antibody interacts with it. No cell death needed, just profound functional disruption.
All right, we've done fixed targets in type 2. Now we move to type 3, where everything's kind of floating around. This is immune complex mediated hypersensitivity.
That's the key difference. Yeah. We're still primarily talking about IgG and IgM antibodies, but now they're binding to soluble antigens that are dissolved and circulating freely in the blood or tissue fluids.
Soluble antigens like what?
Could be proteins from bacteria, components shed from viruses, or very commonly in autoimmune diseases like lupus, it could be the person's own soluble stuff like DNA fragments or nuclear proteins that have leaked out of damaged cells. The main point is antigen meets antibody in the circulation.
Forming these immune complexes, little clumps of antigen and antibody stuck together.
Exactly. Antigen-antibody complexes swirling around in the bloodstream.
Okay, so they form in the blood. Why do they then cause problems in specific places, like the kidneys or joints? Why don't they just keep circulating?
That comes down to the deposition phase. This is really the critical step in type 3 pathology. It generally happens in 3 stages. First, the complexes form in the blood, as we said.
Right.
Second, these circulating complexes get deposited in certain tissues. They tend to lodge preferentially in places with high blood flow and high pressure, where plasma is being filtered.
Like?
Think of the tiny capillary loops in the kidney glomeruli, a major filtration site.
Right.
Also, the synovial fluid in joints, the choroid plexus in the brain, and just the walls of small blood vessels in general.
Yeah.
These areas act almost like passive filters that trap these circulating complexes.
So the body's own filtration systems become the sites of injury. Makes sense. But what determines which complexes get trapped? Are all complexes equally bad?
No, definitely not. Size and the ratio of antigen to antibody are absolutely critical here. Well, if you have a huge excess of antibody compared to antigen, you form very large complexes. These are generally cleared out quite efficiently by phagocytic cells in the liver and spleen, so they don't cause much trouble.
Okay, big ones get cleared. What about tiny ones?
If you have a massive excess of antigen, you form very small complexes. These tend to stay soluble and are often too small to get readily trapped in those filtration sites. They might just get excreted without causing significant inflammation.
So it's the Goldilocks principle. Not too big, not too small.
Exactly. The most dangerous, the most pathogenic complexes are typically those of medium size. These are formed under conditions where there's a slight excess of antigen relative to antibody.
Why are they the worst?
Because they're large enough to activate inflammatory pathways effectively, but still small enough and formed in the right ratio to remain soluble in the circulation for a while, allowing them to travel to distant sites and then get trapped in those vulnerable vessel walls or filtering structures.
Okay, so the medium-sized complexes get stuck in the kidney or a joint or a small blood vessel wall. What happens then to cause the damage? That's step 3.
Step 3, inflammation and injury. Once these complexes are deposited, they act like little inflammatory landmines. They strongly activate the classical complement pathway right there in the tissue.
Just like in type 2 inflammation.
Very similar outcome, yes. Complement activation releases C5a again, which is that potent signal calling in the cavalry neutrophils and monocytes flood into the area where the complexes are deposited.
And they cause the damage.
They cause acute inflammation of the vessel wall that's vasculitis. The activated neutrophils release their damaging enzymes in ROS, leading to intense localized injury, destruction of the vessel wall tissue, and often it triggers local blood clotting, thrombosis, which can cut off blood supply downstream.
The textbook example of this happening systemically is serum sickness, right? What does that teach us?
Serum sickness is the classic prototype, yeah. Historically, people got it after receiving large amounts of foreign protein, usually antibodies made in horses, horse antiserum, used as antitoxins.
Okay.
The patient's immune system would see this horse protein as foreign. It takes time, maybe 7 to 14 days, for the patient to mount their own antibody response against it.
Ah, the
A
delay.
crucial delay. Once the patient starts making enough of their own IgG against the horse protein, then you get that condition of slight antigen excess, formation of medium complexes, and widespread deposition. Symptoms like fever, rash, joint pain, arthritis, and kidney inflammation, nephritis, typically show up about 10 days after the initial exposure to the foreign serum. It perfectly illustrates the time needed for the adaptive antibody response to kick in and form those pathogenic complexes.
And when pathologists look at tissues damaged by type 3 reactions, what do they see? You mentioned fibrinoid necrosis.
Yeah, morphologically, the hallmark is this acute vasculitis. And within the damaged vessel wall, you often see fibrinoid necrosis. Under the microscope, it looks like this smudgy, bright pink eosinophilic area. It's basically where plasma proteins, including fibrinogen, which turns into fibrin, have leaked out of the damaged vessel and mixed with the deposited immune complexes and cellular debris. It's a sign of severe vascular injury.
And in the kidney.
And the kidney glomeruli, because the complex is deposited in distinct little clumps along the basement membrane, if you use immunofluorescence microscopy, using fluorescent antibodies to detect the deposited IgG or complement, you see this characteristic granular or lumpy bumpy pattern. That granular staining is the absolute signature of immune complex deposition disease. Very different from the smooth, linear staining you might see in some type 2 diseases like Goodpasture.
Got it. And just quickly, there's a localized version too, the Arthus reaction.
Right. The Arthus reaction is basically type 3 happening in one specific spot, usually the skin. Imagine someone already has circulating IgG antibodies against a particular antigen. If you then inject that specific antigen directly into their skin,
Complexes form right there.
instantly, right there at the injection site. Massive local complex formation, rapid complement activation, intense neutrophil recruitment, and you get severe localized vasculitis. This can lead to thrombosis in the small vessels and ischemic damaged tissue death due to lack of blood flow, often showing up as a red, swollen, sometimes necrotic lesion a few hours after the injection.
Okay, we've worked through the antibody-driven types, IE, IgE, IE fixed EGM, and then RE fixed EGM complexes. Now we hit type 5e, which is completely different because it throws antibodies out the window, right? This is all about T cells.
Entirely T-cell driven, yeah. Type IV hypersensitivity, or T-cell mediated hypersensitivity, causes tissue injury primarily through the actions of activated T lymphocytes, specifically CD4 plus helper T cells and CD8 plus cytotoxic T cells.
And no antibodies involved means the timing is different too.
Absolutely, because it relies on T cells getting activated, proliferating, differentiating into effector cells, and then migrating to the site of the antigen. The whole process is inherently slower than antibody or complement reactions. This is why it's often called delayed type hypersensitivity, or DTH.
Okay, so let's break down the T cell pathways.
Right.
The source mentions two main ones. First, the CD4 plus T cell pathway, which seems responsible for that classic DTH reaction.
Correct. The DTH reaction typically takes a good 24 to 72 hours to fully develop after re-exposure to the antigen. What happens is, previously sensitized memory CD4 plus T cells, primarily the Th1 and Th17 subsets, recognize the antigen presented by local antigen-presenting cells. They get rapidly activated.
And then they orchestrate the damage.
They do, mainly by releasing powerful cytokines. These cytokines then recruit and activate other inflammatory cells, which actually cause most of the tissue injury.
Let's focus on the Th1 pathway first. That seems to involve activating macrophages.
Yes, the Th1 pathway is central to many chronic DTH reactions.
Yep.
Activated Th1 cells secrete a crucial cytokine, interferon gamma, IFN-D.
Interferon gamma, what does it do?
IFN-8 is the single most potent activator of macrophages known. When macrophages in the tissue encounter IFN-8, they undergo a transformation. They become classically activated, or M1 macrophages.
What does that mean, classically activated?
It means they get bigger, angrier, and much more efficient killers. They ramp up their ability to engulf and destroy microbes. They present antigen better. But they also start spewing out massive amounts of destructive substances.
Like what?
Lysosomal enzymes, codiases, reactive oxygen species, ROS, nitric oxide, pro-inflammatory cytokines. Basically a whole arsenal designed to kill pathogens, but which inevitably causes significant damage to surrounding host tissues if the activation is sustained.
So the macrophages are trying to clear the antigen, but their sustained activation causes the chronic inflammation and injury we see in DTH.
That's exactly it, especially if the antigen is something the macrophages can't easily break down, like the components of the tubercle bacillus, Mycobacterium tuberculosis, or certain fungal
What
elements.
happens then?
With persistent stimulation, these activated macrophages undergo further changes. They can enlarge dramatically, develop abundant pink cytoplasm, and start to resemble epithelial cells. We call them epithelioid cells. These epithelioid macrophages often fuse together to form multinucleated giant cells.
And this leads to granulomas.
Yes. These clusters of activated transformed macrophages, epithelioid cells and giant cells, typically surrounded by a rim of lymphocytes, mostly T cells, form a characteristic structure called a granuloma. Forming a granuloma is the body's way of trying to wall off a persistent, indigestible threat. But the granuloma itself, with all those activated cells continuously releasing mediators, becomes a focus of chronic inflammation and can cause significant tissue damage and scarring over time. The tuberculin skin test for TB exposure is a classic example of inducing a localized DTH reaction that involves macrophage activation.
Okay, so Th1 drives macrophage activation and potentially granulomas. What about the other CD4 plus player, Th17?
Th17 cells contribute significantly too, particularly to the recruitment of neutrophils. Th17 cells primarily secrete cytokines like IL-17 and IL-22.
And what do they do?
IL-17 is especially potent at recruiting neutrophils, and also monocytes, to the site of inflammation. So while Th1 cells are busy activating macrophages, Th17 cells are calling in the neutrophils. The resulting DTH reaction is often a combined assault involving both classically activated macrophages and neutrophils, both contributing to the inflammation and tissue damage.
Can you give a common example of DTH that most people might recognize?
Absolutely. Contact dermatitis, like the rash you get from poison ivy or poison oak, is a perfect example of DTH.
How does that work? Isn't that an allergy?
It is a hypersensitivity reaction, but it's type E cell mediated, not type I IgMast cell mediated. The chemical in poison ivy, urushiol, is actually too small on its own to be recognized by the immune system. It's a halfton.
So what happens?
Urushiol binds to normal proteins in your skin. It chemically modifies them. These modified cell proteins now look foreign to your T cells. Upon first exposure, you get sensitized, develop memory Th1, and possibly Th17 cells specific for these altered skin proteins. On re-exposure, these memory T cells get activated in the skin. They release their cytokines, IFN, IL-17, recruiting macrophages and neutrophils. And voila, 48 to 72 hours later, you get that characteristic itchy red blistering rash, pure DTH.
Okay, that makes sense. Now, the second major pathway in type AVI, direct killing by CD8 plus T cells, the assassins.
Right. This involves cytotoxic T lymphocytes, or CTLs. These are CD8 plus T cells that are specifically trained to recognize and kill target cells, displaying particular antigens on their surface.
What kind of target cells?
Typically, cells infected with viruses, displaying viral peptides, tumor cells, displaying tumor antigens, or, crucially in the context of hypersensitivity and autoimmunity, host cells displaying self-antigens that the CTLs mistakenly recognize as foreign. Also cells from a foreign tissue graft.
And how do they actually kill the target cell? What's the mechanism?
The DTLs have two main ways to induce apoptosis, or programmed cell deaths, in their targets.
Okay, what's method one?
Method one is the granule-dependent pathway. The CTL latches onto the target cell. Then it releases the contents of its specialized granules directly onto the target cell membrane. These granules contain two key proteins, perforin and granzymes.
Perforin sounds like it makes holes.
It does. Perforin molecules insert themselves into the target cell membrane and polymerize, forming pores or channels.
Letting the granzymes in.
Exactly. Granzymes are serine proteases. They slip through those perforin pores into the target cell's cytoplasm. Once inside, they activate cellular enzymes called caspases. And activating caspases is the molecular trigger for apoptosis. The target cell essentially commits suicide on command from the CTL.
Efficient. What's method two?
Method two is Fas-Fazel mediated.
Yeah.
Activated CTLs express a protein on their surface called Fas ligand, Fas-Lal. Many target cells express a receptor called Fas, also known as CD95, when the Fas-L on the CTL binds to the Fas receptor on the target cell.
It also triggers apoptosis.
Yes, it directly activates the caspase cascade through a different pathway, but the end result is the same: programmed cell death of the target cell.
And where is this direct CTL killing clinically relevant in hypersensitivity or autoimmunity?
It's central to several important conditions. It's a major mechanism in the rejection of solid organ transplants. The recipient's CPLs recognize the donor cells as foreign and kill them. It's involved in tissue damage in some viral infections, like viral hepatitis, where CTLs kill infected liver cells.
And autoimmunity.
Critically, it's believed to be the primary mechanism driving the destruction of pancreatic beta cells in type 1 diabetes. The patient's own CTLs specifically target and eliminate the insulin-producing cells in the islets of Langerhans, leading eventually to absolute insulin deficiency, selective, targeted destruction by the body's own assassins.
Wow. Okay, so we've really mapped out these four fundamentally different ways the immune system can cause damage. What's striking now is how this detailed understanding of the pathology is actually changing how we treat these conditions, right? Moving beyond just hitting the whole system with a sledgehammer like steroids.
Absolutely. That connection between the underlying mechanism and modern therapy is probably one of the biggest advances in immunology and rheumatology in recent decades. We're getting much smarter.
Especially in type I allergic diseases, it seems. The source talks about stratifying patients, like this Th2 high versus Th2 low idea in asthma.
Yes, that's a fantastic example of precision medicine in action. It represents a huge paradigm shift. We now recognize that not all patients with, say, chronic asthma or atopic dermatitis have the exact same thing driving their disease at the molecular level.
So how do you tell them apart?
Clinicians can now use biomarkers. They might measure the number of the eosinophils in the blood or sputum, or look for high levels of specific Th2-associated cytokines like IL-4, IL-5, or IL-13, or measure total IgE. Based on these readouts, they can classify patients into having either a Th2 high phenotype, meaning their disease is clearly driven by that Th2 eosinophil pathway, or a Th2 low phenotype, where those markers aren't elevated, suggesting their inflammation might be driven by other pathways, maybe more related to neutrophils, infections, or environmental irritants.
And why is making that distinction so incredibly powerful for treatment?
Because it allows for incredibly targeted therapy. If you know a patient has Th2 high asthma, driven heavily by, say, IL-5, causing eosinophil recruitment and activation.
Then you can target IL-5 specifically.
Exactly. We now have monoclonal antibodies, biologics, designed specifically to block the action of IL-5 or its receptor, or antibodies targeting IL-4 and IL-13 signaling, or IURIG itself. These drugs are predictably going to be most effective, potentially dramatically so, in that Th2 high group.
Whereas giving an expensive anti-IL-5 drug to a Th2 low patient would be
Pointless. A waste of resources and potentially exposing the patient to side effects for no benefit. This stratification allows us to match the therapy directly to the underlying mechanism in that specific patient subgroup.
That really is the definition of personalized medicine, using the pathology to guide the prescription.
It is. It minimizes trial and error, maximizes efficacy, and avoids unnecessary treatment. And this principle is expanding. Even thinking back to those type 2 innate lymphoid cells, ILCs, we mentioned in type 1.
Yeah.
Now that we know they're early responders activated by epithelial damage, researchers are actively looking for ways to specifically target ILC activation or their cytokine products right at the barrier surface. The idea is maybe you could intervene even earlier, preventing the whole adaptive Th2 cascade from fully developing in the first place.
Fascinating. And this applies beyond type I too, presumably,
Right.
knowing the specific mediators in type 2 or 3.
Definitely. For instance, knowing that complement activation is the immediate trigger for neutrophil recruitment and damage in diseases like Goodpasture type 2 or immune complex vasculitis type 3 has spurred the development of drugs that specifically inhibit components of the complement cascade, like C5.
Offering an alternative to just massive doses of steroids.
Exactly. It's about finding more precise points of intervention based on a deep understanding of the specific pathway driving the injury. The whole field is moving toward much more nuanced, mechanism-based therapies, which is a huge improvement over the broad immunosuppression we relied on in the past.
Okay, we have covered a lot of ground here, charting these four distinct ways the body's defense system can essentially backfire. Let's try to distill it down. For someone listening, what are the absolute key takeaways for understanding this whole spectrum of hypersensitivity?
I think the main thing is to remember those four fundamental mechanisms defined by the primary driver. Type 1, immediate, driven by IgE cross-linking on mast cells, releasing histamine and other mediators. Think allergies, anaphylaxis.
Right.
Type 2, antibody-mediated against fixed targets, driven by EGGM binding to cells or matrix, leading to destruction via phagocytosis or complement neutrophil activation, or causing dysfunction by blocking stimulating receptors.
Okay, fixed targets.
Type 3, immune complex mediated, driven by circulating EGGM complexes with soluble antigen, depositing in tissues and triggering complement neutrophil inflammation, vasculitis.
Circulating complexes.
Type 4, T-cell mediated, no antibodies here, driven by CD4 plus T cells activating macrophages via IFN and recruiting neutrophils via IL-17 for delayed inflammation, DTH granulomas, or by CD8 plus T cells directly killing target cells.
And understanding which of those drivers is at play, IgE, complement, IFN gamma, CTLs, that's really the key, isn't it? It unlocks everything else.
It absolutely is the Rosetta Stone, as you put it earlier, because the mechanism dictates the timing, immediate versus delayed, the type of inflammation, eosinophils versus neutrophils versus macrophages, the location of damage, the clinical symptoms you observe, and most importantly, the logical therapeutic approach.
Yeah. Rapid swelling and bronchospasm. Think histamine, leukotrienes, type I. Neutrophil-rich inflammation, destroying a blood vessel. Think complement activation, type 2 or 3. Chronic inflammation with granulomas. Think activated macrophages, T cells, type 5.
Precisely. That mechanistic understanding moves hypersensitivity from being just a confusing collection of diseases to a comprehensible set of pathways with predictable consequences and potentially targetable steps. It provides clarity.
And seeing how this understanding now links genetics like HLA types predisposing someone all the way through to specific cytokines being released and then to the design of targeted monoclonal antibody drugs, it really feels like we're gaining an incredible level of control over tweaking the immune system.
We really are. The progress in the last couple of decades has been phenomenal. And it does raise some profound questions as we look forward, doesn't it? A final provocative thought, perhaps, for you listening.
Go on.
If we know that specific HLA alleles can make someone susceptible to reacting badly to, say, ragweed pollen, or predispose them to attacking their own pancreatic cells, and if we're developing increasingly precise tools to block specific cytokines or modulate T-cell responses or even edit genes, how close are we really to using detailed genetic profiling not just to predict someone's risk of developing these diseases,
But to actually intervene before it happens? To maybe fine-tune or re-engineer that faulty immune regulation before the allergy or the autoimmunity ever manifests clinically?
could we one day design the perfect immune system? One that retains all of this power to fight off infections and cancer, but is flawlessly programmed for self-tolerance, perfectly regulated, and resistant to these hypersensitivity reactions.
Yeah. Wow, that is the ultimate challenge in immunology, isn't it? Balancing defense and self-preservation perfectly.
It certainly is. Something to think about until our next deep dive.